Hey everybody, welcome back to Pharmland. I'm Bradley Nelson and I have my co-conspirator Tom Davies on the line. Tom, how are you doing, man?
Hey folks, I'm doing well. How are you, Bradley?
Hey, doing good, man. Certainly appreciate the opportunity to bring another topic of discussion today. So today we're actually going to talk about pharmacy counter sticker shock. And so we're going to really be diving into what a member will actually pay for their medications. But before we do that, I just want to make sure that everybody knows that Pharmland, we're here to serve with the freshest pharmacy information and insights to benefit advisors, employers, and anyone else for that matter looking for a better understanding of the industry. And we'll take the biggest topics, dig deep, offering perspectives you won't find anywhere else. And as always, Pharmland is brought to you by Farm to Table, an educational program from RX Benefits. So the question of the day, Tom, who is ultimately responsible for helping to control the cost that an end user, a patient, pays at the pharmacy counter?
It's a really great question because there's a lot of factors that impact what a patient pays. But just to level set for the audience, I'm hopeful that you've listened to the podcast just prior to this one where we talked kind of about the pricing alphabet. WAC, AWP, AMP, rebates, to try to get an idea of the upstream impact of pricing. When I say upstream, the manufacturers, the distributors, the PBMs, the pharmacies, what pricing plays within that ecosystem. And now we're going to kind of touch off on what it means for a member paying for a prescription at the counter. And there's a variety of things that really go into ultimately what the member is going to pay for the drug they've been prescribed. So we're going to touch up on those topics. To start, Bradley, I have limited retail experience. I'll be completely honest with the audience here. I know that you've had prior retail experience. How did pricing play a role for patients filling prescriptions based on your retail experience?
You know, when it comes to retail experience, it's usually January where the rubber hits the road for any new pharmacist in the retail experience. That first time that somebody comes up to you and goes, hey, last month I only spent $10 on this medication. Now you're asking me to spend $68. And then you get an education, sometimes with choice of words involved of the patient in terms of how much they're spending out of pocket. And so that's really the initial sticker shock that a pharmacist at retail has to learn to explain. And that is the topic of deductibles and high-deductible health plans. Those are always fun discussion, Tom. And I think that's a good place for us to start if you want to kind of talk a little bit about high-deductible health plans for the audience.
I certainly will. And we would hear, while at the health plan I worked at, we would offer two types of plans. The traditional offering that had, set copays and a premium associated with that. And then at the health plan, we also offered a high-deductible plan, which had little to no premium associated with that, but required the patient pay full freight until their deductible was met. And we would get calls, January timeframe, every year to convey the misunderstanding that now the deductible has reset. I've never had a deductible before. Why has this changed? What has happened? So it's really important for the patient to understand when it comes to a high deductible plan, what will it look like for them until the deductible is met? And oftentimes what that will mean is paying the quote-unquote cash price for a medication prior to the deductible being met. So it goes from a generic that had a previous copay of $10, now, like you said, $68, at least for a portion of the year until they've met their deductible.
And I think it's a really good point. We have an audience that spans employers, benefit advisors, HR reps, and there might be a patient on here, a member or patient. So from an HR and a patient point of view, open enrollment, which coincidentally occurs about this time of year for a lot of plans, this is the time to start asking questions or providing additional educational context. Because Tom mentioned traditional versus high deductible health plan. And when you think about those two things, that indicates patient choice or employee choice. What plan do I want to do? Do I take a lot of generic medications where I can afford to pay out of pocket? Well, maybe I need to look at the high deductible health plan and then expect that my costs are going to go up before they go back down again. If I take a lot of expensive medications, a lot of specialty medications, or brand name medications, well, maybe the affordability might not necessarily be there as well. And we'll talk about how you can manage that affordability or how manufacturers play into that in just a moment. But you might decide that you want a traditional flat copay or flat coinsurance where things are more predictable, that you don't have that initial beginning of the year sticker shock. So I would encourage any patient and HR representative to take the time to educate on the differences between the two so that people can make informed decisions on where they want to go in terms of how much comes out of their paycheck in terms of a premium versus how much they need to pay out of pocket at the point of sale or retail location for this. So I think that's an important piece, but it's not the only piece, is it?
No, it's not the only piece, but just to add a little bit to that, oftentimes when we have benefit discussions, right, plan renewals, we have the ability that if nothing's changed, just check a box and you're going to move forward. No changes been made, no changes to your dependents. It's important that I think an additional message gets set that, yes, your deductible is going to reset starting 1/1 of the following year, and this is the impact of the deductible resetting. So once the deductible has been met, right, or if a patient is on or a member's on a traditional plan, they have their benefits generally structured in such a way that you have flat copays, generally for a generic, right, and then for the alternative tiers, the higher tiers per se, you may have a coinsurance. And so I've had conversations with clients and plans in the past that have a little bit of disconnect between a flat copay and a coinsurance. So how is that determined and why is it determined?
Honestly, it comes down to the richness of the plan benefit. When you're dealing with a flat copay, it's predictable. It's easy to communicate. It's easy to understand by someone. A coinsurance has to take into all those factors we talked about on our last episode of the podcast. What is the actual cost of the medication? How is it processed at the pharmacy? And we talked a little bit about things like AWP minus a discount plus a dispensing fee, and that gives you a gross ingredient cost of the medication. Well, that coinsurance, whether it's 10, 15, 20%, it's based off that ingredient cost. So that is something that's not necessarily communicated or visible within the realm of pharmacy benefits. Now, there's some ways that you can find that information, but it's not readily available. If I'm thinking $20 for a brand preferred or $40 for a non-preferred brand, well, I don't have to think about it as a patient. I don't have to think about it as an HR representative. It just, they pay that, they know what it is, and the plan picks up the rest. But the problem is the plan picks up the rest, so you have to balance things out from how your plan is financially, how stable your plan is financially.
And I think these different factors all play a role, right? To ensure not only are drugs accessible and affordable to patients, but then they also they're structured in such a way that they preserve the benefit, right? I've spent a lot of time in managed care and in health plans, and one of the things that impacts me the most is once you lose an attribute to a benefit, very seldomly do you get that back. So having a process in place that not only, like I said, ensures access to drug, but then also preserves the benefit moving forward for these plan members, that's the balancing act. So we talk about flat copays. There's oftentimes when it comes to benefits, they may have a flat copay for generic medications, $5, $10, $12 for a generic medications. Then you look at the preferred tiers, maybe a coinsurance. That coinsurance can be anywhere from 10, 20, 30%. I've seen some coinsurances that have either no max or a max. So you pay up to $75 for the medication. And then lastly, there's the non-preferred tier. So a higher coinsurance without a max or a higher max. So ultimately, when it comes to the drugs, outside of generics, generally or tier 1, how are these decisions made to place them on a formulary? Is it arbitrary in nature?
There's nothing arbitrary about the decisions for whether something is a preferred medication versus a non-preferred. Generally, and again, these are more general statements that you can follow, is that when you have large manufacturers working with large pharmacy benefit managers, or even smaller pharmacy benefit managers, there is something that we like to term the market basket approach. So if I am Eli Lilly, for example, I have drugs like Zepbound, I have drugs like Mounjaro, but I also have my insulins. I also have drugs like I believe Emgality is a migraine medication that is also on their formulary, on their provision of medications. So when you look at those types of medications, you can potentially negotiate a larger rebate. So last episode we talked about rebates. So sometimes rebates can actually cause your ultimate cost, your net cost, to drop down. So sometimes manufacturers will market their entire basket to a PBM with a good, juicy rebate in order to have lower net costs. So if that lower net cost, if that net cost happens to be lower than a competitor group, say Novo Nordisk, which also does a lot of the same categories that
portfolios, various drug disease states that they treat.
Exactly. Yes. They have very similar categories. They may prefer Eli Lilly products, and that becomes a tier 2. And the reason why they prefer it is the higher the utilization of drugs that Eli Lilly has, the better of a financial situation Eli Lilly can compensate to the PBMs that ultimately get pushed down to a plan, an employer group, so that the dollars get spread out and can be used to buy down premiums so that a patient doesn't have to pay a higher premium year over year. So a lot of market dynamics, but at the same time, Tom, to your point, it's a village approach. It's not a one claim, one drug approach. It's how do I create a sustainable benefit for the entire membership.
So why is tiering important to a member, right? And I'll maybe even answer this question is as a clinician, if a member can't or a patient can't afford the drug, then it's likely the wrong drug. So understanding your formulary as a member is vitally important. Is there lower cost alternatives that's potentially a generic that's available that I'm able to afford and therefore take? Because we do know the impact of walkaways associated with some of these higher cost medications, or potentially a medication that's on a higher tier that's ultimately going to cost more to the member. There's a recent study from IQVIA. I believe it was 2020, I believe. So it's not like last year, but this gives us a representative example of what we would expect secondary to walk away rates based on formulary coverage and tiering. So I'm just going to reference some notes really quickly here. But if you look at prescription abandonment rates are less than 5% when the prescription carries no out-of-pocket cost. Reasonable. Once it rises to over $125, your prescription abandonment rate is 45%. And then, as you can imagine, as it continues to increase, the abandonment rate does as well. So once you get above $500, your abandonment rate is closer to 60%. So these are impactful measures. Members not filling drugs, and this accounts for there's particular medications that we have studies on associated with higher abandonment rates. Hypertensive medications for the utilization to decrease your cholesterol, medications for diabetes. All of these we know that going without your medication or potentially rationing your medication ultimately leads to increased health costs downstream. So looking at your benefit, ensuring that your benefit is built in such a way that we've touched on this, that the member can afford their drug, but then it's also something that will preserve the benefit moving forward. Because you can go the opposite end of the spectrum and transition and push more of the responsibility back to the member. But you have to realize in doing so, your abandonment rates are going to increase.
And I think everybody has probably seen the theme that we talk about a lot when it comes to pharmacy. There's always a balance. Employer groups have to decide what is their healthy balance. And that means, what's my typical employee paid? What's the salary ranges of my typical employee? What's my turnover rate of employees? Do I have a whole bunch of seasonal workers and then abandon them? Do I need to afford a benefit for those folks? Do I need to, there's a lot of puts and takes when it comes to pharmacy coverage and even to some extent medical coverage. And that actually is something I do want to bring up just for a second, Tom. I know we're talking about pharmacy, but pharmacy and medical do work hand in hand when we're talking about a comprehensive benefit. And we talked a little bit earlier about deductibles and about premiums, but that premium is not just for pharmacy. It is, and that deductible may or may not be just for pharmacy, right? There's a complication that we probably need to just hit on for just a moment. So, Tom, can you just briefly kind of talk a little bit about how some of the concepts we just talked about, how it's not just a pharmacy thing, that it needs to be also inclusive of medical, if I'm an HR person and having to educate my folks?
Right, because generally it all comes from the same bucket of funds, right? So understanding that there's going to be some level of integration between the pharmacy and the medical benefit. And if you have an embedded deductible versus a non-embedded deductible, all of these play a role in ultimately how much the member may expect to pay out of pocket prior to meeting their deductible or maximum out of pocket. So it's just that nuance based on the plan selection when it comes to the coverage of the medical benefit is something, like you said, something that may be missed here because we focus a lot of our attention on the pharmacy benefit, but taking that into account is vitally important.
Yep. And so we'll talk about areas where members can manage their pricing, how much they pay out of pocket. But I want to hit on something that's very annoying. And then I want to move to something that's very fun to talk about. So one of the annoying things that I used to get is when someone would come to my pharmacy, and this is me as a pharmacist, where they say, well, I just came from Walmart down the street, and they're about $2 cheaper than you. Why are you more expensive? I know it's only $2, but $2 for some people, that's meaningful. And so, Tom, why is there different amounts just from going from a pharmacy half a mile down the road to this pharmacy here? Why are there differences there?
So it's really comes into play when we talk about just buying power, right? And contractual agreements that are associated with these distributors that may impact the cost of the drug that the patient may pay at the counter. We would have some level of variation while at the health plan that I used to work at, where members may pay $2 more at the CVS versus the Walmart or the Walgreens. So there is some level of variation, and I think that as we wrap this episode up and we talk about, how do the patient member, how do they become educated consumers? And what are some of the options that are available to them, right, to ensure the ability to take the medication because it's affordable?
And I think with that, we need to educate our members on something, on our listeners on something extremely important. Tom, I hear that you now have a service animal that you...
The importance of mental health, right? Yeah. And one of those... aspects of mental health is the potential use of a support animal. And I've been traveling a lot lately, and so I've seen my share of support animals.
And you probably need extra support for yourself, right?
Right. Dogs and cats. In fact, I made a recent trip to California, and there was a passenger on a plane that had a support parakeet. She had 2 parakeets in a mobile cage that she brought on the plane with her, which is fine, just as long as they don't sit by me. No, I didn't mean that, but I read a recent story. Could be worse. There is an emotional support alligator that was first reported by NPR in May. This alligator is 6 feet long. It is owned by a gentleman named Henny, I believe. He's had this alligator for about 6.5 years. And what made this a story was, first of all, he's from Pennsylvania. In Pennsylvania, it's perfectly fine to own reptiles. They traveled with Wally the alligator, this gentleman did, to a friend in Georgia where somebody stole the alligator overnight, put it in a neighbor's yard before Henny could find the alligator. That neighbor called the Division of Natural Resources in Georgia, who captured the alligator, Wally, the emotional support alligator, then took this alligator to a nearby swamp and dropped him off. So now Mr. Henny is trying to find his alligator, and he's being supported by his Facebook group that's raised over $10,000 to help him travel to try and find this alligator. In addition to his Facebook group, this alligator has over 150,000 TikTok followers and has become very popular amongst emotional support animal fans. So pretty wild story. Mr. Henny did say that Wally is very important to him, just as important as his kids are. So I've got a cat that I love, but I wouldn't say that cat as important to me as my kids, but maybe because I haven't adopted an alligator yet.
Got it. Well, for those that might be older, Gen X's or older, then you will know when I say this is a heavens to Murgatroyd moment. Yes. Obviously, Tom just admitted that he is a Gen X or Boomer generation, so by that laugh. So he totally got it. Hopefully some of y'all will get it as well. I do have a wicked, twisted sense of humor in some cases. So hopefully Mr. Henny will be able to find Wally Gator. And maybe next time we'll talk about the emotional snagopus.
If you're in Georgia and you find an alligator that likes chin rubs or likes to be hugged, there's a real potential you found Wally.
I wonder who in the world is going to try to figure out if that's Wally.
Yeah, this is. I would not advise.
Well, Mr. Henny manages his own problem, which hopefully those that are listening in Georgia can be on the lookout for. I want to ask Tom, how can consumers manage what they pay? Go, yeah, you saw what I did there. That transition is so good. What consumers can do to manage what they pay at the pharmacy. So, Tom, give us some ideas.
That's a really good question. Knowing what is on your preferred drug list or formulary is extraordinarily important. Having that resource available when you're meeting with your physician is vital to ensure that this is a streamlined process. That is one aspect. Another aspect is, as insurances change year over year, make sure your pharmacy has the updated information. There's walkaway rates just because they don't have the updated information and the pharmacy is now charging you a cash price. And then speaking of cash prices is then utilization of programs like GoodRx or Single Care, just to price the medication you're on. Just to give you a representative example, that if I'm going to look at a medication, that if I'm on a high deductible plan, is there a way that I could offset some of the cost by utilizing this price? Or if I'm on a traditional plan, there's the opportunity potentially to pay, less of a price than a copay would be. So those are some of the strategies that I would recommend. What about you, Bradley? What else would you recommend there?
Yeah, I agree with you. Knowing your formulary, know where it sits on a tier. But understanding your actual benefit that you talked about a minute ago in terms of deductibles, because things change all the time. HR Benefits has to weigh whether or not they are going to increase the deductible year over year, or need to see if you have a high deductible health plan, how much do I want to have out of my paycheck so that I can use that and set that aside? And in some cases, there are some plans out there, health savings accounts out there, that you can actually invest those dollars while they sit and you're not using them. So if you're not sitting and using them, what can you do to potentially grow the healthcare dollars that you've pulled out of your paycheck on a pre-tax basis so that you can carry that over and grow it and roll it over year in, year out? It's one of the best things about high deductible health plans. Just ask questions for understanding on how you can use those so that you can afford something that might be more expensive. And as Tom mentioned, start with generics. Ask your doctor, can I be treated with a generic medication? That is the most important thing that you could potentially do. Don't be fazed by what's on TV.
That's a tough one.
Don't be fazed with what's on TV. Don't look at TikTok. Don't look at your next door neighbor in jealousy and say, they're on that medication and I know that's why they're feeling full. Because quite honestly, some of these commercials make you feel like you need to have a specific disease state so that you can live a wonderful life because they make it sound so good. But don't buy into the hype. Do research. There's a lot of good places that you can do some consumer research. If you want to go to, even goodrx.com, some people look at that just for some research. Drugs.com, it's very high level information that you can be provided out there. General calls, things of that nature. And then a lot of PBMs that you work with have member apps, right? So price it. Go into the member app and type it in, see what it's going to be. And if it's something that you look at and has a sticker shock before you get to the pharmacy, just show it to your doctor and say, look, I can't afford this. What else can you do? Those are the pieces that I usually recommended when I was across the counter, or sometimes ask your pharmacist, is there an over-the-counter alternative for this? Or what should I ask my doctor? Get your local pharmacist involved, and they can help steer you as well.
And I think that while we've seen significant amount of change, right, within the healthcare marketplace, I think one of those key factors was COVID.
Yep.
If you look back, the unemployment rate went from about 4.5% to well over 10% early on in the pandemic, which ultimately meant that people were going without insurance. And so there was some resources that were available where they talked about some strategies. One of them being potentially is there the option to split your tablet if you can get to a lower cost dose by splitting a 50 milligram tablet versus a 25 milligram tablet. So those are some strategies that can be discussed because, like I said earlier, if the patient's not on the drug, it's the wrong drug, right? There's opportunity once you have the benefit in place, right? We've changed a little bit. The unemployment rate isn't quite as high anymore, but looking at some of the strategies associated with mail order versus 30-day retail, that may be impactful to a member in driving down some of their out-of-pocket costs. So there's a lot of strategies out there, and it's just so important to be educated, right, prior to getting to the pharmacy counter. So you have the ability to have an educated conversation with your physician. And then once you get to the pharmacy counter, you're not going to be surprised by anything. It's that sticker shock that we want to revisit there, that these patients going to the counter to fill their drug, they're surprised by the cost of these medications. It's going to be $850. Well, I can't afford $850. Now, that could have been resolved with the conversation with your provider early on based on the tools that are available. So just utilizing what's available within the marketplace, I think, is so important to ensuring that you're on the right drug and you can afford the drug.
Exactly, because as you mentioned, Tom, if you have that affordability, you're more likely to get it on a regular basis. Your adherence to the medication and compliance to taking that medication goes up. And the prevailing theory is if an ounce of prevention is worth a pound of cure. If I can prevent a medical event, as a patient, as an employee, the better off that you are. So again, it's education. It's 95% of what pharmacists do is to try to educate the public, whether it's a patient, whether it's an HR person, whether it's a broker. doesn't matter. The more, I hate to use the more you know comment, but seriously.
Just need a rainbow.
Just need a rainbow with a star. But it really comes down to that. The more you know, the better off you will be, and the better off your health will be when you, as a patient, the more empowered you are based off the knowledge that's being imparted to you. So ask questions of your doctor, of your HR benefits folks, of, go online, search.
Of your pharmacist.
Of your pharmacist, yeah.
Yes, of your pharmacist at your pharmacy. Do I need to take this medication, right? Do I have other medications that I'm currently on that the provider wasn't aware of, and now there's a duplication? It's unnecessary for me to take this, not only from cost, but then it puts me in enhanced risk of just adverse effects. So just having that open-ended conversation, right, with your provider, with your pharmacist, with your HR director, ultimately leads to success.
And this is just a shameless plug for pharmacists out there. At this time of year, you have National Pharmacist Month or American Pharmacist Month. That usually takes place at this time of year. And just to kind of throw that in there is once you find the pharmacy that you like, I do want to encourage not to spread all your medications and to think of pricing to such a degree that you have 10 different medications at 9 different pharmacies. You also, as a consumer, should look at a market basket approach and try to get all your medications best price for all of them at one place. That way, one person can help you manage your benefit from your side of the counter. And that's where that local pharmacist can come in. That's even where a mail order pharmacist or a specialty pharmacist can come in as well, because they know what you're taking, when you're taking it, why you're taking it, and so on and so forth. So it's extremely important to have an accountability partner, and the pharmacist is a really good person to have on your side to help manage your medications.
What a fantastic call out. Kudos where kudos is due. I do a lot of research prior to us meeting and having our podcast recording, right? In preparation. So that is a vitally important call out that you just made to ensure that everybody remains on the same page, while there may be some detriment to have 9 different prescriptions spread out at 9 different pharmacies. So well done.
Yep.
Bradley, well done.
And just to kind of tee us up for the next time, our original question that we were asking everybody, who's ultimately responsible for helping to control the cost and end user pays? It's a little bit of everybody, including the person that actually pays for the prescription. But even if things are high, just to kind of tease you up for the next segment, a lot of times when I was at the pharmacy counter, I would recommend something called a copay assistance or coupon card in order to help promote affordability. So the next time, Tom, I think you're going to be able to hit that one hard. There's a lot to say there.
It's really worth a discussion for sure. Pros and cons associated with these programs. So looking forward to the discussion.
All right. But until that next discussion, I'm Bradley Nelson.
Tom Davies.
And we're Pharmland. Y'all take care.
And once again, please like and subscribe. Please send any comments our way, questions, concerns, additional topics you would like us to discuss. Just had to throw that in, Bradley.
Nope, fair. Because without you, we would have nothing. So thank you.
Appreciate it. Bye, guys.
Bye.